I'm Jonathan Yap from the National Heart Centre, Singapore. And today it gives me a great pleasure to introduce the fourth webinar in our series of CHIP Summit. This CHIP Summit series is brought to you by the APSC Young Community in conjunction with the Transcontinental CHIP Case Sharing Club. Today our topic is on a practical guide to Antegrade CTO PCI. This event is supported by the Singapore Cardiac Society and is accredited by EBAC. Today, I'm happy to have with me Dr. Jonathan Sung from Hong Kong to co-chair this session. And we have prepared a stellar lineup of speakers. We have two keynote lectures going to be delivered by Dr. Lam Ho from Hong Kong and Dr. Shozo Ishihara from Japan. We have two exciting cases prepared by Dr. Muenpetch from Thailand and Dr. Dharmaraj from Malaysia. We have a very experienced lineup of panelists to help in the discussion. We have Professor Jack Tan from Singapore, Dr. Aisha Kadir from Bangladesh, Dr. Vishnu Aditya from Indonesia, Dr. Faisal Habib from Indonesia, and Dr. Purik from Thailand. Some housekeeping rules. The content of this webinar is copyrighted by the APSC, and the views and opinions expressed are those of the faculty members. This webinar will be live streamed via APSC Facebook and YouTube pages. Importantly, I want to highlight that, if you have any questions, please use the Q&A icon at the bottom of your Zoom screen and post your questions on the chat. We will try to address some of these questions during the discussion segments. I want to give a quick shout out to an important upcoming webinar. The APSC Young Community has organized a series of webinars over the next couple of months, addressing key topics in general cardiology. To give an update, the first webinar will be on the 13th of September, and this will talk about updates in acute cardiovascular care. So please do sign up if you are free. Without further ado, I'd like to hand over the platform to my co-chair, Jonathan Sung.
Thank you very much, Jonathan. It's my pleasure today to welcome you all to our fourth APSC Emerging Leadership Summit. As Dr. Yap has mentioned, our focus today will be on Antegrade CTO PCI, and it's my honor to introduce our first speaker today, Dr. Lam Ho, who's an interventional cardiologist from Tuen Mun Hospital, Hong Kong. He is a renowned interventionist with vast experience and also a lot of innovative ideas about intervention. He is also my teacher and a friend of mine, and today I look forward to hearing his teaching on choosing the right wire for Antegrade CTO PCI. Please, Dr. Lam.
Oh, thank you, Chairman, for the introduction. Today I'm going to talk about how to select the right wire for Antegrade CTO. Actually, this is a very stressful topic, particularly today I see many experts in the audience side, also in the panelist side. So I just try to share out my view. So my talk will talk about selection of wire, about the concept, the theory, and some practical tips, mainly this three part. For the concept on selection of wire, my concept is that think about the world, what is the most beautiful color? Actually, it's very difficult to say which one is the most beautiful, red, blue, or yellow, or green. It depends which color you like. Actually, for the wire, which wire is the best for the Antegrade CTO? Most of the time, it's operator's preference, and the best is the most suitable one. It depends on your skill, your character, everything, and whether you like it or not. And another important concept is that which color is most beautiful in this environment. Of course, green is most beautiful. In this environment, white plus blue probably is the best. So which color is the best depends on the situation. Which wire is the best also depends on the situation and the purpose. Actually, the best is the most suitable one. If the wire can help you to settle your purpose, then this one is the best. These are the two important concepts. And another thing is wire. This I learned from Paul Cow. Is wire when you repeatedly use, you very familiarize. and become your familiar friends, and we pay the arrow, and wire is then will become your wife. So you can't have many wives. You need to be familiar with the wire you like, and except you are the king of CTO. Of course, for a king you can have many wives. Yes. Otherwise, maybe just few. So, and then we are talking about the theory for the wire. I think it's very easy to find it in internet. Wire usually contain of coil, digital tube, coil, and coating. All these elements. So this is something in general. So I will focus on three most important things on the wire. One is the tactile feedback. Actually, in all the theory, all the books, you will find that for hydrophilic wire, more hydrophilic, then the tactile feedback will be less. For hydrophobic wire or no coating, then the tactile feedback will be very good. But in my experience, I found that in reality, that is not true. Actually, it's how familiar with the wire, how you familiar with the wire, that is more important. This factor is more important. For example, like filter XTA, if I use a lot, I use it for many years, I found that I can have a very good tactile feedback for the wire that I'm familiar with. So this may not be true. I had heard from many great operators. They also had the same comment. They will have more tactile feedback with the wire that they like. And the second theory is about the tube control of the wire. So the torque control actually is integrated of all the things, the coating, the wire design, and the shaft, everything. So it's not particularly one factor that make it have a good torque control. I can show you in the old day, the wire will move like this with some jacky movement, with some whipping effect. Actually, the good Antegrade CTO wire, you have to test it in virtual, in model, and then you found that actually it's really one-to-one torque, no whipping effect, and then you move one angle, 1 degree of angle, then you move 1 degree of angle like this. So for me, my comments that in reality, yes, true. For example, some series like Gaia series, it really have this behavior, but not all the wire, not all the Antegrade CTO wire. So this no whipping effect. Probably nowadays the best torque control wire in my experience is Clin family. Actually, it's really you can see when you talk 1 degree, then the output is 1 degree, and it's true. I tried, but the structure of this wire is very complex. You had add-1 design, X-trend, this coil design, everything. It's true. The torque control, torque response, really very good for this family, and I don't have any disclosure for that. And the last important feature of wire in Antegrade CTO is the penetration power. Actually, it's not just tube load, the shape and size of the tube will also affect the final penetration power. For Gaia family, because of the shape design, although the tube load may be the same, but their penetration power will be higher. Of course, the strongest, despite it put it like this, I still think Conquest Pro 12 or 20 Conquest series, the penetration power is the strongest. However, Gaia series, Gaia Next series, particularly had better torque control, and it is a wire that with penetration power plus the torque control. So these are the three important character of the wire, three important performance of the wire. And for selection of wire, I got a 4-element theory. Whether the wire can successfully do the CTO or not, of course, fail, you change. There are only 4 key elements that you can change in your procedure. One is your wire. Of course, for example, you fail filter XTA, you change to Gaia, or fail Gaia, you change to confianza pole, something like that. One is change of wire. Second is change of wire shape. You think clearly, only these 4 elements that you can change. And the thing that I want to highlight is that don't just think about the wire. Actually, your supporting microcatheter and the guiding will also affect your wire performance. Finally, of course, is change of operator. These are the 4 elements that can help you. There are 4 elements that they are the factor that you can change for successful wiring. So I try to illustrate these 4 elements. Talk about the practical things with real case. The first case is talk about wire and the supporting microcatheter. For example, like this case, you can see that it's a CTO without stump. There's a side branch over there, and of course, I try Corsair plus field XTA. I cannot go. It just go to the side branch, and then now you can see that with proper wire and supporting microcatheter, we use Crusade and then Gynex 2, and then with more control and then a guide 2, and then we can puncture to the true lumen. Case 1 show the change of wire and change of supporting catheter that make the difference. And case 2 show about the step up and step down of wire. Sometimes you because the stump of the CTO, particularly for Antegrade CTO PCI, the stump usually is stronger, more stiff. Sometimes you really need a very high penetration force to penetrate. For example, like this wire with LED CTO, this case LED CTO no stump, and very very old CTO. There's a big side branch over there. Despite I use Crusade assist, and then I try to puncture with field XTA, Gaia, and even Congress Pole 9, but cannot puncture. And then I have to step up to Congress Pole 12 to puncture a small hole. After that, you have to remove your Crusade and then replace it with your usual microcatheter, for example, Corsair, and then step down for travel. Because for CTO, you should think about it into 3 parts. One is the stump, Antegrade stump, the proximal cap, and then is the CTO body. Proximal cap is very hard. The CTO body is very soft. And then is the distal cap is harder than the CTO body, but softer than the proximal cap. So for travel, usually I will use Gaia or filter series, less strong wire, less penetration wire. If you use Conquest Pole, you travel all along the CTO, most likely you perforate. So it's not very safe. It's better to step down. So for integrated wire, the selection, after you are finishing your purpose of puncture, then you should step down to the wire with less penetration power, so that you can travel more safely. So all the selection is all based on your purpose. So that's final angiogram. And then the case 3, we have to select the wire with some wisdom. Like the previous case, we always use strong wire, and then step down something. But it's not like this. It all depends on the situation. Depends what are the case you are facing. Depends on the purpose. Then you may use different strategy. For example, like this case, osteo-AD CTO, it's lucky the patient has CT done before. Calcium score was very high, more than 1,000. It's osteo-AD CTO, but if you look carefully from the CT, actually there's a small stump in the osteo-AD. After that, a heavily calcified AD. And then we try to see from the angiogram, you can see there's a side branch, a small side branch, but it seems there's no stump. But from CT, there should be one stump for the LED CTO. So in this situation, we have seen the CT. We found that it should not be very hard, a bit soft in this part. So in this way, in this situation, I use one balloon as anchor balloon on the side branch. You also block the entrance, then increase the support from the guiding, everything. And then I use a soft wire, filter XTA, and then try to search this small stump to enter it first. I use a lot of time to search this entrance but I do not use a strong wire because if you use strong wire, it's very easy to go into subintimal. That's very important. You can see from the model and you will understand in this sort of situation, if you cannot enter the true lumen, if you use strong wire, you just slip and then go to the sideway, you can puncture in, and then you put your microcatheter in, then it will be a disaster. In such a calcified lesion, it's very difficult to re-enter the true lumen. So just introduce for the soft wire Antegrade, quite commonly is filter XTA or R. You can shake in special shake, use different view, and then I can find the small stump. Of course, the soft XTA wire cannot cause. You just need to enter, and then I push the microcatheter in and lock the microcatheter in the cap, in the proximal cap, and then I step up the wire. And then wire should be guide second this case, and then wire the true lumen. So this case just demonstrate to you that it's not just strong wire puncture and then step down. Sometimes you have to use soft wire first and then step up. All depends on the situation. So we had talk about case to illustrate the wire and the use of different supporting catheter. So how about the wire shake? Besides changing the wire, changing the supporting microcatheter, wire shake is also very important. I try, but there's one practical tips I want to share. Not all the wire that can be shaped without cord. For example, like the Gaia, they're all pre-shaped wire because the structure is very complex, so that they can maintain this one-to-one torque. If you want to shape it with secondary curve, something, or very big primary curve, something, then it may damage. Actually, for this wire, the torque control can be damaged if you shape it a lot. So in some situation like this case, the patient had a osteo PL CTO, angulated PL CTO. And then if you want to wire many times, you need to shake it. I had tried to use different wire. I cannot wire. Then for this case, I use UB3 because UB3 you can shake it, but the torque control usually can still be maintained. And shake it with primary curve and secondary curve so that it's more easy to search the entrance. Of course, Crusade is better in this sort of situation. This is the picture to illustrate the Muenkaew family. Of course, put a wire over there, then Crusade, and then you bring your shifted UB3 down to the PD and then pull back and then try to search and then search out the entrance, search the proximal cap and then puncture it through it, just like this. Okay, search and then puncture. And because you already had a secondary curve and primary curve, you cannot travel with this wire. Otherwise, most of the times you end up in subintimal. So remember, you have to stop at this position because of the secondary curve, and then you have to change the Crusade, change back to the Corsair, and then change to Gaia or field XTA with a small primary curve, and then try to puncture, and then you can enter the true lumen. This case we just treat with DCB. Okay, so we have go through wire shake and supporting catheter, microcatheter. It did make difference. The most common one probably also guiding. Don't forget guiding. Guiding is also important. For example, super core, something like this, sometimes can completely change the procedure. I got a case that I had shared in UPCL. I try to share this case to illustrate sometimes special supporting microcatheter is important. This is osteo AD CTO. Yeah, osteo AD CTO. And then very funny case. This is really very funny case. I try to wire. You see the wire. In this view, it seems okay, but in spider view, you see there's a sharp turn. I don't understand. I try to wire more. And then you can see the dynamic view. In our cranial, it looks like this. Actually, it's a spiral. From spider view, you can see there's a big turn. In fact, in this sort of situation, it's very, very difficult to use microcatheter. Most of the time, you just push the microcatheter in and then it will prolapse. I try many microcatheter, Corsair, Corsair, Caravel. All the microcatheter fail. I push the microcatheter in and then it just prolapse because it cannot turn like this. And then finally, I choose one is Mitsuki Fax. This microcatheter actually can help me to turn and then provide support, and then I can go and then finish the procedure. Just use this case to illustrate. Sometimes on top of the wire, you need to think about your microcatheter. Mitsuki Fax, Supercourse, Caravel, Turnpike, all have different properties, and they can affect your wire and affect your wire selection. And, course, the first CTO and then second CTO, something like this, and then finish. Okay. So after all this case, then I think you get more inspiration on this concept. Which color is the most beautiful? Always depends on your purpose and your environment or situation. Like this situation, you put a blue spot, it won't be the most beautiful color. In this situation, if you put a green, is not, but it doesn't mean green or blue is not a good color. And the final thing for Antegrade wire ring, of course, parallel wire is very important. This is a LED ISR CTO. There's a stand in the mid to distal AD. It's undersized stand, so ISR and have some problem. The major problem is this angulation. With such an angulation, most of the time Gaia somewhere cannot cause. And after this curve, most of the time you will lose the control. And for those undersized ISR, it's very challenging because you don't go outside the stand strap. You have to go through. So I can't use Gaia, strong wire, everything. I need to shake the filter HTA and so that I can enter. But after shaking the primary curve, secondary curve, of course, I cannot enter, go to the true lumen. I go there and then with some support, I can push the microcatheter to the edge of the stand. And then I have to change to a more controlled next one to have better tactile feedback and better torque control, so that I must enter the stand. Don't go outside the stand strap. I must enter the stand. After enter the stand, I push my microcatheter in and use piping to make sure I'm inside the stand strap. And then I can try to wire. I try filter XTA with just a Gaia shape, one primary curve and a Gaia next series, but I cannot enter the true lumen. I cannot exit the distal cap. In this sort of situation, of course, the best is parallel wire. In this situation, I will use Sasuke double lumen catheter, not Kusei, because the difference is the causability. Sasuke had higher causability. Despite this turn, most likely it can cause to this area to enter the stand strap, enter the ISR. And there's some minor difference between the Sasuke and Kusei is the exit port. For the Kusei, it had a 26-degree exit port. The wire sometimes once it exits the lumen, it will have some turn, but Sasuke is direct go out, and then in this case is more suitable. For parallel wire, I will highly recommend Gaia next V because you need to puncture from the force to the true lumen, puncture some layer of some structure of the vessel. So you really need a puncture penetration ability together with torque control. So puncture and then finish. So that is the summary of my talk about the selection of wire for Antegrade CTO. The concept, the best color is the best fit one. And theory, I had briefly talked about the wire design on how it affects the field, the torque control, and the penetration power. And for practical aspect, this is my 4-element theory. The things that you can change for Antegrade CTO wiring, probably just 4 elements. You depends on the situation. You just change either 1, 2, 3, 4. See which situation you change, which also depends on your skill, depends on your thinking and your belief. And that's the end of my presentation. Thank you.
Thanks, Lam Ho. I think you actually covered a very, very important principles that I hope our audience will be able to appreciate some of the clinical pearls that were shared. Maybe I'll start with a bit of philosophical question that maybe I can ask Vishnu. People always say like, hey, what's your favorite wire, or what kind of escalation strategy that you usually use, when doing a kind of like Antegrade CTO PCI. Do you have any thoughts to share on that?
Well, yeah, as you asked about philosophical question, and this topic is about Antegrade CTO, but really, I think the paradigm is already changed, and nowadays it's just about the strategy. So we don't really differentiate about Antegrade and retrograde CTO anymore. For example, whenever I see a good retrograde collateral, if it's possible, I always try to put a wire there. It's not necessarily a CTO wire, so it usually just act as a marker. But just by putting a wire there, it will efficiently reduce my contrast, reduce my radiation, and in my opinion, it really increases safety. And you will always have a backup plan if the Antegrade doesn't work. So I think you cannot differentiate them. And in case of what usually I do in my wire strategy, I think it's almost the same as Dr. Ho mentioned. Usually you have 1 or 2 favorite wire using XT or XTA, or sometimes a fighter wire from Boston, which has the tip load around 1.5 or so. And very intrigued that Asahi just launched the new Gladius wire, which seems really good as the first wire choice to try for Antegrade. Thanks.
Maybe I can ask Jack as well. With regards to this Antegrade wire escalation strategy, do you have a preference of wires? What's your thinking about how you escalate the wires as well?
Yeah, I think Lam Ho did a fantastic introduction to this. So thanks to Lam Ho. I actually do very similar to what he does as well. Just I like his pointer about being a good friend to the wire until it becomes a wife. But I think a lot of us as mistresses. So for some of my colleagues in China, Professor Zhang Ping, for example, he needs to travel often, and he really just have one wife. To keep it simple, he crossed everything, we just cross it 200. I think we're privileged to have this escalation, so I just briefly talk about my preference. I usually use a lead-in wire because to guide workhorse wire to bring the microcatheter up, always with a microcatheter. The other thing about the guide is that sometimes upfront you may want to plan the Antegrade approach with a slightly larger guide, so it's more fitting with a guide extension or a double microcatheter approach or parallel wire approach. And I actually go straight with Gaia Series 2 and then just use a Gaia wire. I rarely use the XT unless I sense that there's really a microchannel that I can feel around. If it's a blunt access, I perforate through with a Conquest series. Then I quickly transit to a Gaia or XT, XTA to feel the rest of the way through. So I just do very simple escalation, failing which I transit much earlier to a retrograde approach nowadays. Thanks, John.
We can also hear from one other of our panelists. Can we ask Dr. Purik, what do you think of this Antegrade wire escalation strategy as well, and what are your tips and tricks?
Okay. First of all, I would like to thank you, Dr. Ho Lam, for delivering such a fantastic talk. So I think so far is one of the best Antegrade lecture in that I learned before. So for me, definitely I will try the Antegrade with I usually begin with the workhorse Y and a microcatheter, same as Professor Jackson do, and then I switch to the filter XT. And if it's difficult to do the penetrating, I will change to Gayasili and then change to the Concasili. If the Concasili fails, so I will begin Litocate. So I will use only TY in the step. And if end up with the Concast pole, so I will early change to the Litocate channel to decrease the radiation dose and the contrast dose. Yes, that's my preference.
Yeah, I think those are very important points, and I just want to, and I'm not an expert in CTO and all that, but from my limited experience, there are really very few, a few of these important principles that I would like the audience to take home. Number one is you need to make sure that you have very good support for Antegrade CTO PCI. So as Lam Ho says, you can have a microcatheter. You need to prepare the Antegrade part, the portion leading to the CTO well. So it's very narrow, you can balloon it in advance. You can use anchor balloons, you can use microcatheter. Basically, make sure you get good support. With regards to the wire, everybody has their favorite wire. As Vishnu has said, recently Asahi has introduced the Gladius, and if you have the opportunity to use it, I would strongly encourage it's great wire. It has been one of my almost go-to start-off wires. I used to use the Filter XT, a bit softer and all that, but some of the cases nowadays, I kind of just start off with a Gladius. Like crossing an aortic valve, I do TAVI, so, like crossing an aortic valve, you can see when someone crosses the aortic valve, whether he or she knows what he or she is doing, right? So for those who don't know, you can see them like just blindly poking the aortic valve. And for those who know, they can actually feel the jet, they know where that hole is, and their actions are very meticulous. So likewise, for Antegrade CTO PCIs, I think when you first start, your control may not be great. Your wire may whip left, right, and so on and so forth. But as seen in some of the Lam Ho's cases, you can see how meticulous he is when controlling the wire. The tip does not swing left and right. He's really probing the lesion, and that only can come with experience. When your wire touches the lesion, it feels hard. You need to escalate. There's no point blindly poking. So that's what he calls the tactile feel, and that can only come, with doing more cases. We are running a little bit behind time, and I would like to introduce our next speaker, who's very, very experienced CTO operator. We have Shozo Ishihara Sensei. He's the department manager of the Department of Cardiology in Mimihara General Hospital in Japan. Today he's going to share with us a very important talk, tips and techniques to optimize success of Antegrade CTO PCI crossing. Ishihara Sensei, please.
Thank you, Chairman. It's a great honor to have a lecture and discussion with very a lot of famous PCI experts. So today my topic is Antegrade CTO crossing. So Dr. Ho already speak about the wire selection and escalation, anything. So that I will focus on strategies and also techniques. I have only limited time, so let me start my lecture. So as you know, there are several algorithms of CTO wire crossing, Asian one and European one, and many algorithms. But these days, this is the newest one. So global algorithm of CTO wire crossing. There are some important points, as you know. One is proximal cap. Confirmation. So it is ambiguous or unclear, or it is clear. It's very important. And next point is proximal. Distal part. Distal vessel visualization. Distal vessel is so very clear or very poor quality. So it's very important. And another point is, are there any important side branch at the distal of CTO? And also, are there any interventional retrograde channel? So it means we have a retrograde option or not. With these factors, we should consider antegrade strategy. And first of all, starting CTO PCI, as you know, it's important to take appropriate CAG, and also reading is also very important. And make use of CT information is also important. If possible, we should do CT coronary angio, checking calcification or vessel course or something. And this is also important, approach site and also PCI system. And as guideline mentioned, CTO entry. So entry point and also CTO distal part. Both are very important. So that we should confirm CTO entry. And also we should visualize this outbreak. So if the vessel is entry, CTO entry is ambiguous or unclear at that time, first of all, careful reading of angiogram, and of course multi-angle, and as you know, frame by frame, very careful angio reading is very important. But sometimes still no entry point at that time, we can use IVAS. So to check the entry point with IVAS. That the entry point is left side or center, right side, we can't understand at that time. We put IVAS. And sometimes it's possible. We can insert IVAS and also microcatheter together like this. And real-time checking IVAS, we can puncture the entry of CTO with IVAS guidance. So this is also very important principle of CTO PCI. So we must advance guide wire into CTO region. Of course, wire escalation, wire selection is important, but the main purpose is to advance the wire into CTO and of course cross the region, so that we should get enough backup support for CTO wiring. So it means including guiding catheter or guide extension catheter, support microcatheter, something. I'm sorry, I have a limited time, so I can't mention guiding catheter section anything. But as you know, it's very important. And also effective use of anchor balloon technique. This is also important. If guiding catheter is limited, if the backup support is enough and not enough at that time, we should use anchor balloon effectively. And also, as you know, using side branch technique. Of course, we can check the IVAS from side branch, and also we can do side branch technique with using double dual lumen catheter. And to get enough backup support, we should use especially 7 French or 8 French guiding catheter for CTO PCI. In some Asian countries, still some doctors use 6 French, but more than larger than 7 French is very important. Enough backup support, and also we can do uncovered technique easily, and also we can use dual lumen catheter also easily with anchor balloon, or sometimes we can insert IVAS catheter and also microcatheter in interventional PCI. And of course, we should sometimes exchange support catheter from microcatheter to dual lumen catheter and so on. And as you know, 7 French guiding catheter can be inserted from radial region now. And if we sometimes use 8 French, for the purpose of 8 French is just IVAS guide wire. If we have no chance of retrograde, at that time, IVAS guide wiring is mandatory. So that 8 French is one option. So what I want to say is we should understand the compatibility of guiding catheter and also IVAS or microcatheter or dual lumen catheter. This is very, very important for CTO wire success. And as you know, anchor balloon technique is very important for not only CTO, but complex PCI. We get a strong backup force like this. This is a side branch anchor, but we should understand also coaxial anchoring technique. And of course, we should consider optimal balloon size, 2.0 or 2.5, and also the position as far as distant as possible. Or to get enough power, we should keep slight pullback force so that the assistant doctor should little bit pull back the anchor balloon. It is also important. And of course, we should be careful of side branch ischemia. So testing or ECG. And if the anchor balloon is not enough at that time, we can advance one more wire besides the anchor balloon so that it get more strong backup force. So I will show one case of anchor balloon technique. This is the RCA CTO, and at the proximal RCA, and the lesion length is very long like this. And the distal part is a little bit bending. I will show later. So first of all, I advance guide wire XTA with the support of Corsair and using balloon anchor technique. This is the side branch anchor, as you know. Fortunately, XTA was advanced to the mid RCA, but it is difficult to advance more. So that it's important to advance microcatheter. So in this case, Corsair, to the in the CTO as far as possible. It's very, very important. For this purpose, balloon anchor technique is very important. Of course, using H-French or using more supportive guiding catheter is also effective, but this kind of anchor balloon is very important. And after advancing microcatheter, I changed the wire to UB3, and so to control and also to intentional wiring. And we can visualize the distal path from the contralateral injection. Finally, like this, wire advanced to the distal lumen. But like this, the distal part is, have the very strong bend, so it was very difficult to advance microcatheter and also small balloon. So for this situation, also anchor balloon is important. Small balloon and 2.0 balloon open up, but still difficult to advance the stent, so that we can use the guide extension catheter. But for advancing guide extension catheter like this is a coaxial anchoring technique, balloon anchor at the distal part and advance my guide extension. Sorry. And so finally, I can deliver the long stent with the distal part with guide extension support like this. This is the final result. Very nicely recanalized. The case was anchoring technique, and next is side branch technique, and also balloon screen technique. I will introduce. So this is the circumflex CTO. This side branch CTO is in the side branch, but the main branch of the CTO, the main branch of LCX have also the stenosis, so that if I put the stent, the side branch will occlude, so that I should open up both. And we can see this little bit antegrade flow, so that I suppose there might be a small micro channel. So I started with XPR because of the existing of micro channels and using dual lumen catheter. But unfortunately, XTR is too weak, and it is easily collapsed to the angle of main branch. So it is difficult to advance. So that in this point, open up the small balloon in the main branch, and to avoid to block the collapsing the wire, and changing to the ordinary microcatheter. So this is the caravel. Fortunately, with balloon screen support, XDR wire could advance into the CTO region. But after advancing more, we can detect this wire is subintimal space. So in this point, we should change microcatheter caravel to DLC crusade again, and using parallel wire technique with Gaia Next 1. And fortunately, wire could advance, but still difficult to cross more distally. In this point, change to from DLC to Caravelle again, and balance screen again. So finally, Caravelle can advance into CTO, and with the support of balance screen and also microcatheter, Gaia Next 1 wire could cross the CTO region with a bending. And after that, crossing the wire, putting two stents, final result is acceptable, very nice. So like this case, if the first wire migrated into subintimal space at that time, parallel wire technique with second wire is of course one, but it is important to start before subintimal space is expanded, so that first wire so control too much and making very large, so hematoma or subintimal space is a very unsuitable behavior. So that quickly start parallel wiring. If we detect the first wire is migrated in subintimal space, it's very important. And the next option is IVAS guide wiring, but it is mandatory 7 or 8 French guiding catheter. Or if we use 6 or 7 French guiding catheter at that time, double guiding catheter. So one guiding is IVAS, one guiding is microcatheter or advancing wire is an option. So and another options, retrograde approach and also ADR. But these are not today's my topic, so that I will focus on IVAS guide antegrade wiring. This is my last case. This case was circumflex CTO. Like this, the CTO region is around 20 millimeter, not so long, but it have the including the bending in the CTO region, and unfortunately there are no interventional collateral, and so that so it is important to visualize the distal vessel. We can see distal part like this from contralateral injection, putting microcatheter like this. And to reduce the contrast volume. So antegrade, retrograde microcatheter, and also antegrade, this is the corsair. Using this kind of microcatheters is to reduce the contrast. And starting with corsair and also XTA guide wire. But XTA is in the porous lumen, so subintimal space, so that using parallel wiring with Gaia Next 2 like this. And unfortunately, Gaia Next 2 also migrated in subintimal space, so that changed to dual lumen catheter, crusade, and also using Gaia Next 3, so more intentional wiring. But unfortunately, wire could not cross the region. And so that with after small band dilation, I advance the IVAS like this, and we can see this is the IVAS probe, and this is the wire which is on IVAS. So IVAS probe is left side, and the wire is right side. This is the RAO view, and also this is the LAO view, spider view. IVAS probe and wire is same line, so that we can understand this is the IVAS image or still image. RAO side, IVAS is left side, and this is the IVAS wire. So wire is right side, like IVAS and wire. And from LAO view, IVAS and wire is on the line, same line. So that we can understand from RAO view, and true lumen is this one. This true lumen is right side of the IVAS. And also from LAO view, true lumen is right side of the IVAS. Both sides, true lumen is right side. So this goes, and also this goes right side. So in this information, with this information, I advance the wire Gaia Next 3 again intentionally for the right side of the IVAS like this. So just function, and also this is a Gaia Next 3. So additional parallel wire right side, and also next course is right side right here. So after advancing with DLC, from DLC to corsair, I change the microcatheter like this. And after advancing cold care, step down the wire from Gaia X3 to XDA. This is very important. Wire step down. Of course, Gaia X3 is easy to puncture, but it is also easy to migrate over interval space again. So step down is very easy. And after that, checking IBUS, this is only proximal part, but proximal part is just intra-plug, inside the plug, you can understand. Distal part is a little bit difficult to get the lumen, so that change the film plug again. So finally, get the totally intra-plug for a whole true lumen with the IBUS guidance. And just to understand, the final result is well recovered. So I introduced the IBUS guide wiring. So this is the ordinary, so conventional IBUS guide wiring. But these days in Japan, we sometimes perform the new ADR technique with using IBUS guide puncture. It is called detection ADR. Already, so published this year. So this is a conventional ADR, as you know. We sometimes use stingray balloon. So, but for this purpose, we should visualize the distal part from contralateral injection. And if subintimal space is too much large, at that time, it is difficult. Or if we should do straw technique or something. And puncture point is a little bit so limited because of the classification or something. But with using the IBUS guidance, we can puncture even from CTO body or just distal of the CTO exit, so distal cap. So we can choose the puncture point, and also we can puncture as with exact vertical puncture. So easy puncture angle we can get with the IBUS guidance. So we detect the tip and wire shaft direction. So it is very easy way. I can't talk anymore because of time limitation, but this is the now topic in Japan. So for this kind of IBUS guide CTO wiring, but for this purpose, so CTO IBUS with both short tip and pullback system should be available all over the world. This one is anti-IBUS, so from Telmo, but I know it's not available in overseas countries, but this IBUS is very, very useful and very important. So this is my last slide. For CTO, 7 French or 8 French guiding catheter is very important. Side branch technique, answer balance technique, balance spring technique, and also IBUS guide wiring. So there are many techniques options we should understand and please use for next video. Thank you for your attention.
Thank you very much, Ishihara Sensei. It's a fantastic talk. I'm sure we all learned a lot from your talk, and there are a lot of new things for us to digest. But since you mentioned about 3D wiring, maybe we just answer this question from the floor. The question is, can 3D wiring be a component of all cases to assess antegrade wire progress? And what is a specific situation where 3D wiring is useful? So Ishihara Sensei, do you have any suggestions for this 3D wiring here?
The wiring of the, I'm sorry.
So the question I think is, what is a specific situation where you will use 3D wiring or 3D wiring?
3D wiring. Yes, I see 3D wiring. I see. So, for example, if we have the enough a very good retrograde option, so very good interventional retrograde channel, at the time, of course, it is a good chance for the retrograde. But in some situation, we have no option for retrograde or very high risk or difficult situation for retrograde. At that time, we can do only antegrade. And if the parallel wire is easy because the distal target is very clear, at that time, we can do parallel wiring with contralateral injection is first step. But if the distal vessel is very unclear, for example, like circumflex CTO or something, at that time, 3D wiring. So using IVUS guided wiring is very effective or effective, if it makes sense.
Thank you very much, Sensei. Personally, I find that with 3D wiring or IVUS guided wiring, you really need to know what you're doing. Like you need to be exactly sure what your wire is looking at, your wire is directing it, and then you need probably multiple views, and then you need to really understand what your IVUS is showing. And most of the time when I look at live cases, it takes me a long time to understand actually what the operator is doing. So, but I'm sure with experience, the technique would be very useful. So, should you have any question for Sensei?
Yeah. Could I ask a question?
Thank you very much, John.
Yeah.
So, do you want to go
Maybe
first?
I shall first and then Lam Ho.
Okay. So sorry.
Apologies. Thank you. Thanks. No worries at all. Thank
Yeah.
you, Dr. Ishihara, for that masterclass and for all the tips and tricks. I did have a couple of questions. One of them is, what is your role, as in how would you say is the role of active support, particularly when you have a 7 or 8 French? I know that there's more utility for active support when it's a slender technique, but in CTOs, what do you think is the role of active support? Formation of loops.
Active support and passive support both important, but for example, first of all, we should consider the how advancing the wire into CTO is difficult, or it's not so difficult. It's a very important point. So that if it is we suppose it's very difficult at that time, we should use, of course, 8 French guiding catheter, or for left side backup type, or for example, for the LAD OSTR, we should use short tip jerkins, or for example, for circumflex, large size of amplats. Such kind of backup is also important. But in some situations, it is difficult to engage or to use 8 French is difficult. At that time, as I mentioned, balloon anchor is also very important option. And so balloon anchoring technique is very easy, but it has some tips or something. So so a little bit pullback, also putting one more wire, such kind of tips also important. So passive and both backup is important. Is it okay?
Thank you. Thank you very much. If I might allow, because I'm amazed at the opportunity to learn from you. What is your granuloplasty technique in case of a balloon uncrossable lesion? Do you keep penetrating wire in situ and then take a balloon? What size balloon? How much would you go up to a granuloplasty technique?
I'm sorry, which kind of technique? I'm sorry.
Sorry, a granuloplasty in a balloon uncrossable lesion. In case of, is granuloplasty a technique that you would recommend for a balloon uncrossable lesion? And if so, what is your approach to it?
So it means balloon uncrossable lesion.
Granuloplasty, bursting the small balloon just in the front of CTO, bursting a balloon.
The intentional balloon rupture.
Yeah. I see. I'm sorry, but I haven't. I have no experience about that. But it's I understand. But I'm sorry, but I have no idea. So that not intentionally making rupture, but to get that, so I can say, and passive back support, and so using small balloon or something is it's more important for me. I'm sorry.
Thank you. Thank you very much.
Just to add, I think looks like we get better and better balloons nowadays. Like the balloon profile are getting smaller and smaller. I personally find that I use less and less granuloplasty nowadays because it's harder to get a balloon uncrossable lesion nowadays with the improvement in the balloon size and profile. So Lam Ho, you have a question?
Yeah. Hi, Ishihara. I think it's a very good chance to ask you some questions.
Yes.
You show us some 3D wiring. So many young cardiologists, including me, I also want to learn how did you train yourself for 3D wiring? I find it sometimes very difficult for IVSky 3D wiring. What is your pathway? How did you train it? How do you train yourself for IVSky 3D wiring?
So yes. So how can I say? For just the case which I show, I introduced is that just angiographical 3D wiring. So so how can I say? Merge the angiography and also IVAS. And these days, our 3D wiring is just IVAS guidance. So with the IVAS using, so we can detect the tip direction. So for example, clockwise 90-degree rotation or counterclockwise rotation or something. So it's a little bit different. But first of all, IVAS guide, so tip detection 3D wiring is I think so more difficult. So that angiographically using area or area or spider view or something. So and that it is merged with IVAS image. It's so first of all, so it feels something difficult, but maybe training it makes easier. So so get used to it is more important.
Thank you very much. I think you're having a very fruitful discussion here. So it's probably time to move on to our case sharing session. So our first case will be shared by Dr. Muenpetch, who is an interventional cardiologist from Thammasat University Hospital, Thailand. So please, Dr. Muenpetch.
Thank you very much, and good evening, everyone. So I would like to share you my case. This is a 68-year-old male who has the hypertension and dyslipidemia. He actually presented to our hospital because of the embolic stroke, but on the investigation, we found the Q wave in the anterior lead of his ECG, and on the holder, we found high PVC burden, and the echocardiogram show the impaired RV function with the anterior wall hypokinesia. So the patient underwent CTA coronary, and on the report, we found the near total occlusion of the LAD from the calcified and mixed plaque. So at that time, the patient underwent the coronary angiography, and there was the chronic total occlusion of the proximal part of the LAD. You cannot see the collateral supply from the left side. And from the right coronary angiography, you can see the tiny collateral to the apical part of the LAD from the RCA here, very distal. And that time, the operator send the patient for the viability test, and the MRI report the subendocardial scar in the mid to apical anterior anteroceptal and infraroceptal wall, and the territory is viable. So he bring the patient back for the CTO procedure, but and he used the Gaia second and try to cross the lesion, but I think because he didn't know the distal target, so he didn't know where to go. So finally, the wire went into the subintima and caused a small perforation here. So he stopped the procedure. And finally, this patient was sent to me, and I decided to do the retry. So before that, I analyzed the angiogram again. And in this case, the proximal cap is ambiguous, and the CTO body is longer than 20 millimeter, and the cause unknown, but no calcification. And the distal vessel is small and very distal at the very distal part of the LAD, and collateral from the RCA to the apical part of the LAD is very small and uninterventional. So at that time, one thing came into my mind. The most important question for me is why it is viable. Because of the poor collateral supply, it cannot be viable in my is my thinking. So, I suppose that maybe there is other collateral supply to the LAD that make it viable. So I go to the radiology department and I review the CT by myself, and you can see that this is the CTO of the LAD. So you can see the mid part of the LAD in this CT, which you cannot see in the angiogram. So that means some vessel feed this mid LAD segment, and you can see that. Maybe you see the collateral, yes. And I can show you this picture. So this mid LAD was filled by the collateral from this branch. Fill the mid LAD, and I trace back, and this branch is the conus branch, but its origin is very early takeoff, almost from the aorta. If you look at the angio again, you cannot see this conus branch from the correct angiogram because the catheter was too deep. Here is almost separate conus artery from the aorta. And for the CTO body, there is a small calcification, and the CTO length is actually not so long. So for the reattempt procedure, I bring the patient back, and at this time, I try to do the angiogram without a deep engagement of the catheter. So you can see the conus branch here. And then I use the microcatheter, put in the microcatheter in this conus branch, and I do the tip injection. So at this time, you can see that the CTO length is not long. It's only this, maybe around 15 mm or less. And here is a target at the mid LAD. So at this time, I know the distal target. I can know the CTO body cause. So I have no fear, and I can go to the correct direction, the right direction with the Gaia third. So I can get to the distal lumen and then check the IRAS. This is a side branch, and you can see that the wire is in the plaque, interplaque tracking, up to the osteo, the LAD. So after that, I put two DS up to the left main. And here is the final angiography. And this is the final I was. So the stent is very expand and approach. So in this case, I didn't emphasize on the technique, but I want to emphasize on the philosophy of know your enemy and know yourself. So know yourself means you have to know your skill, your CTO wiring technique, and from your experience you can tell the feeling from the wire, and you have to know all of your device. And for the enemy, I think don't jump into the fight unless you have been carefully analyzed of the angiogram and the CT and the IVAS about the proximal cap and the CTO body and the distal vessel and the collateral and the CTO pathology as well. And you have, and in this case, I think the first operator failed because he didn't know the distal vessel, so he cannot know where to go. And we have to learn from the failure of other doctor or from your past procedure. So if you cannot answer yourself what was the failure of the previous procedure, why it failed, you will be fail again, I think. And about the collateral circulation, you have to check both intercoronary collateral and the extracardiac coronary collateral. And the most common extracardiac coronary collateral is the bronchial artery and the internal mammary artery. So if you cannot find it on the coronary angiogram, you have to check for the CT, and don't forget the separated coronary artery from the aorta as well as in this case. Thank you so much.
Thanks, Muenpetch. Yeah, it was an excellent case, and I think that a very important take-home point for our audiences is that careful case preparation is so important. You can see how meticulous Muenpetch was. He knew that the LED was viable, and he really searched hard for a collateral, and that really changed the whole game. Maybe I have a question for you, Muenpetch. We know you did very careful planning, but could we understand a little bit more about your strategy? We know that the proximal cap was a little bit ambiguous even after you found the conus collateral. How did you overcome this problem of ambiguous proximal cap? And did you straight away start with a guiated wire, or did you start with something softer?
Oh, okay. So I skipped this. When I analyze the CT, I also get the information about the proximal cap. So where it is and what is the cause of the vessel. So I think I get some information from that, because in this case I think we cannot use the IVAS guide puncture directly from the left main, because there is some channel into the LED before the CTO. It's not the ostial LED CTO, it's a proximal LED CTO, and there is no side branch at the proximal cap to use the IVAS guidance. So I use just only the CT information. But if I fail, I think I have to do the IVAS guide puncture. Maybe from the first wire, if the first wire went into the subintima, I will use the IVAS guide re-entry. Yes.
And can I just follow up with my second question? Did you straight away start off with the guiated, or did you
yes. Yes. In this case, I step directly to the Gaia, because I want the precise puncture. So the first operator, he already tried the XT, and in this case I think I know where to go, so I didn't hesitate to use the Gaia. Yes.
So once again, I think, from the little comments from Muenpetch, we have a lot of learning lessons. Number one, once again, he saw what the first operator did. And with the softer wire at the start, already the first operator was not successful. He took home that lesson. And number two, if you understand what the proximal cap is, and Muenpetch got quite a lot of information from the CT, there is no harm in straight away starting with stronger wire if you know exactly what you're doing. And maybe I have a question for one of our panelists, maybe Faisal. How often do you use CT planning, in CTO PCI? Do you use it often or only in select cases? And when would you choose using a CT?
Thank you, John. It's a very excellent case from Dr. Muenkaew about use of CT angiography for guided us to puncture and to see the proximal cap in circulation. I think, but the interesting point of this Dr. Muenkaew case is that maybe all of us, the interventional cardiologists, should know how to read the CT for angiography, because it's very helping us for choosing what is the best wire to do and where's the route for the CTO. In my practice, I use a CT, not always in my CTO patient, but in patient with angiography, it seems very calcified, and we don't know where's the stump, and also we don't have a clear distal vessel like this case. But I think the question is, if Dr. Muenkaew become the first operator for this patient, there's still he used the CT, or because the patient has failed to the first operator? I think it's interesting question to ask to answer. Thank you, John.
So Muenpetch, the question is, if you were the first operator, would you have stopped, or would you have gotten a CT first and then go ahead, or would you have gone ahead right off?
You mean if I didn't study the CT before the procedure?
Right. Yeah, let's say if you were the first operator. I mean, at the first time.
The first doctor.
Yeah. I know, but if I were the first operator, I think I should check the CT first before I start. So because I think on the same image, or the same image, the radiologist and the interventional cardiologist will focus on different things. So like for the CTO, the radiologist will report only is 100% occlusion. But as we are the interventional cardiologist, we have to check a lot of things. We have to check about the cause of the vessel, about the calcification, about the how is the distal vessel, or how is the proximal cap. So in my practice, I usually check the CT by myself. In every case that had the CT, sometimes I do the reconstruction by myself, because the radiologist sometimes use a different angle, not the angle that we use for the procedure. So I think everybody should check the CT by yourself and reconstruct it into the view that you do the procedure. So if I were the first operator, I think I should check the CT before the procedure. But if I already start the procedure and I fail, I have to stop. I have to stop and think again what happened and what is the mechanism of the failure. And when I can answer myself by go back to the CT and review it again or something, then I will start the reattempt. Yes.
That's very great lessons. Maybe you just take one comment, maybe from Jack, just to get a variety of opinions. When would you use a CT for CTO PCI? Is there select cases, or are you more liberal with using some of these CT scans and planning?
So I think the first procedure, clearly a lot of things that Muenpetch that he did that was not done besides the CT planning, the contralateral analysis. an injection, a microcatheter lead, the appropriate wiring and the wires, and the ability to think upfront about how to upscale and escalate. When we talk about CT, I am not certain it's actually required for every case. I think in my mind, it'll be very useful for a failed case, and particularly the cause is ambiguous and the collateral doesn't reach. For example, RCA that is tortuous or circumflex artery. I think those are particularly the ones that I think is very, very useful when the contralateral injection is unclear and the cause is unclear. So I think those, when you overlay, I think is very, very useful. It's particularly whether you look at it yourself or not. Whether you need a CT angiogram as a pre-procedure planning routinely for all CTO intervention, I would be hesitant to say that it's true for all CTO pre-planning, but I think it's definitely useful, particularly if you can read it yourself, not depending on radiologists. I don't know whether anyone does it as a routine. The other question in my mind, although it's not the topic of today, is when do you need to do the CTO? So it is a big topic by itself. I think in this case, an LAD CTO showing viability is a good target to be had. But I would say that if, like in the recent stroke and all this, you need not necessarily need to open up all CTOs immediately. Just a pointer there. Thanks a lot.
So that's a good pointer raised, and that's a topic for another discussion on its own. So once again, I would like to thank Muenpetch for that excellent case. And another very good point to highlight is, if you do a CT, you need to read it yourself. That's extremely important so that you really take full use of whatever information that you get. There's no point ordering a CT and not using the information that you get. So for the very last case, it gives me great pleasure to invite Dr. Dharmaraj to give this talk. He's an interventional cardiologist and the head of the Cath lab in Hospital Sultana Bahia in Kedah, right, Malaysia?
Yes, yeah, that's right.
So,
hello, Star.
Excellent interventionist, and I think we got a lot to learn from his case. So Dharmaraj, please.
Thank you. 1 second, let me get my bearings here. Can you see my slide?
Yep, you're good.
Okay. Thank you very much for having me, John, and everyone. Today, I'm just going to cut the introduction short. The topic of my case today, I've given it a title, The Road Not Taken. So I hope you will learn from my mistakes here and you will not repeat it. My patient is a 64-year-old Malay gentleman who has several cardiac risk factors, had multiple visits to the emergency department with acute coronary syndrome and cardiac asthma, and he was erroneously treated as COPD, exacerbation, and an astute clinician luckily saw and referred him to us. An echocardiogram showed an ejection fraction of 45%, and a coronary angiogram showed a CTO of the ostial LAD. We sent him for an MRI, and the MRI came back that the LAD was viable. This is the angiogram, and as you can see, it is a blunt stump at the ostial LAD, and it's one that you do not know, you don't have a track to even suggest where you need to puncture. And this is the circumflex artery, and this is the worrying thing to do ostial CTO intervention is the fact that you do it in a dominant circumflex because you have a very narrow window to save yourself if anything happens. And this is the left main, which is relatively free of disease. To make matters worse, the right coronary artery was anomalous, and the conus branch was providing the epicardial collateral to the distal LAD. And so when we planned the CTO LAD, we decided to use a 7 French catheter with contralateral injections from the femoral side, a 6 French, and using an AL catheter to engage the RCA and a 7 French EBU 3.5 for the intervention to the CTO LAD. And whenever we engage the AL catheter, actually the BP dampens because of the angulation. So we had to keep it slightly out and just take a non-selective injection, as you can see here. And there is two, you can see that it is quite a long CTO segment, and decision-making, involves the length of the CTO segment. And we know it's an ambiguous stump with a JCTO score of 3. This is a dominant circumflex with a tortuous retrograde epicardial collateral coming from the right side, which it's very dangerous for us to use to do a retrograde, because if anything happens and we damage this collateral, the patient is going to deteriorate very fast. There's a small epicardial collateral coming from the diagonal branch, through the diagonal branch from the circumflex, as you can see here, but this is very close to the distal cap of the CTO and one that cannot be used. So the safest approach here is to do an antegrade approach with IVUS guided puncture. And if this fails, we explain to the patient who actually refused surgery that one option is to do a minimally invasive cardiac surgery, Lima to LED. That would be the safest. So we put in a cyan blue wire into the circumflex artery, and we did an IVUS pullback and marked, as you can see here, the location of the ostium. The IVUS catheter is there. The location of the ostium was marked not only with IVUS, but with angiography as well. And this is the IVUS pullback, as you can see, from the circumflex artery. The left main is relatively free of disease with a very large lumen of almost 6 mm diameter. This is the area of the bifurcation, and you can see the stump, and the IVUS image is playing above. You can see the stump of the LED and where we need to puncture. The ostial circumflex is relatively free of disease. And this is where you need to puncture. If you're going to do an IVUS guided puncture, keep it in the middle and not at the peripheries, because that's when you will enter the subintimal space. So we used a fielder XTR, and I used a fielder XTR in a fine cross with a secondary curve, because it is recommended that you use a secondary curve when you're doing a CTO at the ostium. And this left main is rather large. So I used a secondary curve in order to guide my wire to the site I need to puncture. But as you can see here, with both the fielder XTR and the Gaia first, I could not hold on and puncture the ostium despite having guidance from the IVUS. And the same thing happened with the Conquest Pro. So I was spent almost more than an hour doing this. So I felt that I needed to stop and reflect and go back to the IVUS images to see if I can find a clue what is going wrong. Because we saw the ostium of the CTO, it wasn't calcified. So I cannot explain why my wire is not puncturing that cap, because it keeps going to the side. So from the IVUS, I noticed something. If you see this IVUS run, you notice that the LED is taking a very long time to appear and join the circumflex artery. So what it means that the angle of the LED is actually much narrower than what I thought. If it's a wide angle LED, as you can see here, it will join the IVUS. If you're doing an IVUS pullback, it will join the main branch in just 1 or 2 frames. But if it's a narrow angle, it will take a very long time. And then, so what exactly happened when I did a secondary curve? So the secondary curve was the bane in this case, because what it does is that this secondary curve allowed, because of the narrow angle, it allowed my wire to go to the periphery of that CTO stump instead of staying in the middle. And when you do a secondary curve, what happens in this last picture here is that even if it's in the middle of that stump, the wire will prolapse on itself because of that secondary curve. So right now, the strategy change would be no secondary curve. But the other clue that I found from the angiography is the stump of the distal collateral from the spider view, which is more superior than where I wanted to puncture. And so this makes a narrow angle CTO ostium a far likely possibility. And this time I wanted to get more support. So because it's a 7 French, I have to use the same wire to send down a dual lumen catheter and use this something similar to a slipstream technique. Using a dual lumen catheter with a wire loaded, with another wire loaded there over the same wire you put your IVUS, because it gives you very good support. And the other reason is because this wire you'd want to follow the circumflex wire, because the puncture is just right next to the circumflex. As you can see here, the wire, in a matter of minutes, we found the puncture, the ostium of the LED, and very gently, we were able to puncture and go in. And so this is what happens when there is no secondary curve on the wire. It stays in the middle of the ostium, of the CTO stump, and allow us to puncture the mid using IVUS guidance. There's some calcification at the distal cap, so I had to use a little bit of force to puncture that with a Gaia third. And then we confirmed the wire distally was in true lumen, and proximally, as you can see from these IVUS pullback from the circumflex, that the wire is in the true lumen, proximally as well. So only then you balloon this vessel, and then when you see antegrade flow with branches appearing in the CTO segment, you know you're most likely in the true lumen. And I tried to wire the diagonal branch, the large diagonal branch that is there at the distal cap, but I could not do it because of the dissection very close to that and this acute angle. So I gave up the attempt to do that. And we started with an IVUS run from the distal left main, from the LED right up to the left main. As you can see, the left main, as I mentioned before, is relatively free of disease. This is the point of bifurcation, and this is the ostial LED CTO, a significantly diseased ostial LED, and this is the proximal LED. This is the calcified segment in the distal cap, and this is the area where the diagonal branch is coming out, and this is the myocardial bridging segment in area number 7. And our distal landing zone is very, very close to a myocardial bridging segment. So what we did was then to prepare this lesion with a scoring balloon, and after that with a 3O scoring balloon, and after that I used a cutting balloon proximally, and as you can see, the vessel has grown significantly after preparation. And then we did another IVUS run. So right now we have found the landing zone distally just before the myocardial bridging area and the ostial, and to land the stent just at the ostium. So the length of stent will be 38 mm from the distal landing zone right up to the proximal landing zone. So then therein lies the problem. Even in the most experienced of hands, to land a stent just before the myocardial bridging right at the ostial LED is a tall order of ask, because the problem is if your stent moves proximally or distally, you're in trouble. You do not want to land your stent in the myocardial bridging segment for the fear of stent fracture, and you do not want your stent to come out too much into the outside the ostial LED. What about stenting into the left main? This left main is large, almost 6 mm in size, and whatever stent you put in, regardless, even if you put a 4 mm stent, it is probably going to be, and even if you expand it as much as possible, it's still going to be slightly undersized and maladposed in the left main. So what if you stent just at the ostium of the left main, ostium of the LED? The problem is in a narrow angle, you can actually end up impinging the circumflex artery. And what if you come out slightly into the what if the stent is at the ostium in a narrow angle at the carina? You may have some stent struts protruding into the lumen of the circumflex. And the problem with that is if you're going to wire the circumflex later and do a procedure, it is going to be difficult when a stent strut is actually jutting into the ostium. So you may end up, either distorting the stent struts or your device may get stuck in that stent. So it may be another different problem altogether. And then you look at the size of the stent you're going to put in. Look at the lesion size, look at the vessel size during the first predilatation, and look at the vessel size after we've done a final predilatation. The vessel is so much bigger now. So the question is, with all these disadvantages of putting in a stent, where you risk landing in the myocardial bridging segment, you risk jailing the diagonal branch, missing the ostium altogether, impinging the circumflex, and landing in a large left main and causing malapposition. Another option available would actually be to put a drug-coated balloon in this area. So why? Because a drug-coated balloon can land in the area of the myocardial bridging segment without any problem, will handle the issue we have at the ostium. It is okay if the balloon comes out slightly outside the ostium, and it also handles the problem of jailing the diagonal branch because the balloon will not do that. So that is exactly what we did. We put a slightly longer 40 mm balloon, a 3.5 40 mm balloon, inflated it at 12 atmosphere over 5 minutes. Why 5 minutes? Because there was a dissection, as I showed you in the mid LED after the balloon preparation. So we wanted to tack it against the wall as much as possible. And this is the final result after we've done the DCB. And it's quite good. And you can see the myocardial bridging happily squeezing away. And this is the other view, and the results were good. So we left it at that. So this patient's EF 2 weeks ago has improved to 60%, and he's on optimal medical therapy and remains asymptomatic and has not had any admission since. So for those who are skeptical of this, there's a similar story of another CTO that I did. And in this patient, it was a trifurcation with a near ostium CTO with a very large left main. So the IVUS showed the same thing, a myocardial bridging distally, and with no clear landing zone for a stent because it is diffusely diseased up to the ostium, you may only have to land in the left main. Landing at the ostium is a very tall order of ask. So we did a DCB for this case as well. And as you can see, there is some spasm here in the area of myocardial bridging, and Ivers showed there's no luminal lesion, so we left it at that. And this is the surveillance angiogram 8 months later, which shows a pristine vessel, and the vessel has grown significantly, and whatever spasm we saw has disappeared. So there are several learning points from this case. Firstly, that antegrade CTO intervention might be the only safest option available in some patients, and Ivers-guided CTO PCI gives valuable information regarding the angle of a branch, and the secondary curve of a wire should be based on this angle, and it's imperative to use Ivers-guided puncture for ostial LED CTO, especially in dominant circumflex, because you do not want to enter a subintimal space at the ostium, because if you put a stent there, it will end up jailing the circumflex artery, and that can be catastrophic. And myocardial bridging and acute bifurcation angle poses a great challenge in stent implantation. And in these patients, DAB is a viable option, provided the lesion is well prepared. And with that, ladies and gentlemen, I thank you very much for listening to me. Thank you.
Thank you very much, Dharmaraj. I think that's an amazing and a wonderful case, especially like the way how you think about the angle of your entry into the proximal cap. I think that's a very thoughtful process, and I personally learned a lot from you, and also the way you handle your stenting versus DCB. I have to say that's a very bold decision to put a DCB in LED with dissection. Do you plan to do a restudy or surveillance angiogram for your first case?
Yes, almost all the cases, complex cases that I do, we will have a surveillance angiogram. More so if you're doing it for an ostial LED CTO, for a CTO segment, because I will usually do a surveillance angiogram within 9 to 10 months.
Interesting. So yeah. Dharmaraj in this case demonstrated how he used IBIS to help his wiring. So Ishihara-san, do you have any comment on this case?
Okay, so for this case, so as I talked in my lecture, so IBIS guided, so puncture is very important, so that you can use Gaia next to free. Gaia next to free is a very so effective wire, but also sometimes makes perforation. But with real-time IBIS guidance, it is so very safe to puncture very hard proximal cap. So and you discuss about the bifurcation angle. So narrow angle, the wide angle. So it is different imaging way of IBIS. So it is also very important and also very interesting point. So and if possible, so as the last case, so CT angio will be also the one option to see the angle of the left main bifurcation. So if that to reduce the contrast, with no contrast coronary CT angiography also effective just for take the bifurcation or angulation, or for example, first case, separate conus branch, we can check without contrast, but CT angiography is very effective. It's my comment.
I think there was a question. Sorry, I think there's a question from Dr. Muenpetch. You know, he wants to know why we did not do the retrograde injection from the beginning. The retrograde was actually the retrograde injection was done during the PCI procedure, but the first angiogram was done 2 months before that. So it was just an angiogram. Yeah.
Yes, but when you start the procedure, you just did the IVAS guidance for the puncture, and at that time you do the retrograde injection at the time that the Y already crossed to the distal vessel to check the Y position, right?
Yes.
I think by that injection should start at the beginning of the procedure, because once you have passed
It was there from the beginning. So the first angiogram I showed you, it was there from the beginning. I already did a dual bilateral injection. So we removed, after that, we didn't want to engage the anomalous RCA. We removed it. We removed the catheter. As I mentioned, because the moment you engage, the blood pressure drops because of the angulation of the catheter, angulation of the RCA. So when you put the AL1 catheter, it engages too deeply. So then the blood pressure drops because the collateral is coming from the RCA, that conus branch. So I had to disengage the catheter. So the first run that I showed, the first run just before we wired and anything, is actually a bilateral injection.
Yes, but when you pass the wire in the CTO body, so how can you know your distal target?
Oh yes, we did that, but I didn't show you the angiogram because of time constraints.
Thank you.
And Parik, if you have any thoughts about this case?
Sorry?
Yeah, Dr. Parik.
Okay, can I have a short comment? Because in this case, it's very nice demonstration from the IVAS that is a narrow angle of the osteo-CTO LED. So I think this case, if you choose Sasuke and Kuse, Sasuke have a narrow angle, which will be better provide to get the osteo-CTO in this case, which I noticed that you use it. Kuse have more wide second lumen angle, and I think the second choice. Do you consider using the super cross 45 angle or 90 angle to get the osteo-CTO LED in this case?
See, that if the angle is wide, but this is a narrow angle. So I would want it to follow where my circumflex wire is going, as I explained, because I want my wire to follow the circumflex wire, and that is only possible with a dual lumen catheter loaded on the same wire that the circumflex wire is on. Supraflex catheter and supercross catheter is actually very useful if you're dealing with an acute angle LED osteum, which even with, and sometimes if you use a second wire, the second wire will, if you use a secondary curve to puncture that, using a dual lumen catheter, your secondary curve will not have enough force. Because of a secondary curve, the puncture force will be lost because it will bend on itself. So that is when I would use a supercross catheter without a secondary curve, just to point at the osteum, especially if it's calcified, to puncture it. The second thing is supercross catheter is something that I will use with a lot of caution because it's very, very expensive in Malaysia. So it is almost, it is twice the price of a normal microcatheter, if not slightly more. So when it's ridiculously priced like that, I do my very best not to use it unless it's absolutely indicated.
So we had a question from the floor about DCB, which I think Dharmaraj already addressed. So we have one last question from Vishnu. Do you have anything to add about this case?
Yes, thank you, Dharmaraj. It was really an amazing case, and it was a very, very insightful presentation. I really enjoyed it, and I learned a lot. So I just want to clarify something, because you use a 7 French system, then you use 2 wires only, and at the first time you put an IFUS, then you put a double lumen microcatheter. Is that right? So the IFUS and the double lumen microcatheter was loaded on the same wire. Correct. So,
yes.
Yeah. So when you did the puncture with the second lumen, that means you're blind. You're not using the IFUS to guide it. Is that correct? Because the IFUS has to be pushed downward.
No, your IVUS marker is placed at the ostium of your, so nothing moves. So when you put the wire, when you put your dual lumen catheter over the same wire where your IVUS catheter is, this is very similar to doing a slipstream technique or the IVUS guided puncture Dr. Ishihara showed. So you put but you cannot use another wire because this is a 7 French system. Only 8 French will be able to accommodate this safely. So what you do is you place the IVUS marker, you place your IVUS catheter, you mark where the ostium is, and that catheter doesn't move. And then you send your dual lumen catheter over that same wire, and it will stop just before, because it's a monorail system, so it will stop just before your IVUS catheter. And then you send down your second wire, the the Gaia third in this case over this dual lumen catheter to puncture the cap, and all the time your IVUS is looking at the cap.
How far is the IVUS eye from the tip of the double lumen catheter? Is it far?
Why don't I show you my case again? So I can actually, I'm not very good at explaining, verbally. So I'll just show you the case and then I'll explain what I did. Oh. So if we were to go back to the puncture.
So for the audience who don't mind, we'll just take a minute or two just to see this, because I think this is a very useful technique
So you
to
see
know.
this. So this is what we do. So the same wire that has the IVUS catheter, you put in the dual lumen catheter. You put in the dual lumen catheter over the IVUS wire, and then leaves this lumen here free for you to send down your second wire. You see here, this IVUS, this is your IVUS catheter, and your IVUS is actually imaging looking directly at that ostium while I'm puncturing with a second wire that is coming from the dual lumen catheter over here. So none of this entire system doesn't move until the puncture is completed. There is also a reason why I had to puncture this without sending down a microcatheter, because when I tried, the problem with this is when you try to move the dual lumen catheter after that, you'll find that, the system might get stuck and you'll pull all the wire out. So there will be a problem when you do that. And you can't send another balloon to do a balloon trap. It is very difficult. So that's how this IVUS guided puncture is done. Did I explain it in the way?
Yeah, you explained it very nicely. My only question is, how far, in your opinion, in your experience, using this kind of double lumen microcatheter, the distance between the second lumen, the wire that came from the second lumen from the IVUS eye? How far is
that's
it?
a good question. I've forgotten the answer to that. So there different catheters, different dual lumen catheters have different. So if you're using, this is a Boston IVUS. So the tip is actually the sheet, at the end is actually much longer than the Navifocus and the one that Dr. Ishihara showed. So the Japanese people have that in Japan. So what we have is only the Boston catheter. So sometimes when I need to enter the subintimal space and the distance is too much, what I do is I cut the end. So I make a slight, I shorten the sheet in the end so that I can send it down a bit further into the vessel. But that is not, you can do that, but that is not advisable. The best thing is for you to use a Navifocus or the anti-owl that Dr. Ishihara just showed.
I see. Thanks a lot. Yeah. It clarifies everything. Yes.
Thank you.
All right. So thank you, everyone. I think we have a very fruitful night of discussion and case sharing. So the night started off with Dr. Lam Ho sharing about how to choose integrate wire in CTO PCI. I think it's really the operator's own choice, and also we need to be flexible, and we need to know the purpose of using that wire. And then Ishihara-san very comprehensively gave us a review on the different approaches on integrate CTO PCI, including the use of side branch anchor to increase their support, and also the 3D wiring and the IVUS guided wiring. And then we had two wonderful cases. I'm sure you all agree. Dr. Muenpetch, he very thoughtfully worked up for his case before he actually did the wiring. And I think that's a very important lesson for us all to, because I think we cannot overstate the importance of preparing for your case before you actually started it. And then Dharmaraj just now illustrated another very thoughtful case about how he tried to enter the LED ostium with IVUS guide, and also thinking about the angle of the entry. So I think the audience and I would agree that we had a very good learning tonight, and hopefully you all enjoyed learning despite being a Saturday night. So thank you everyone, and I will close the session today, and we look forward to seeing you all in the next session. Thank you very much.
Thank you. Excellent session, everyone. Thank you for your time. Thank you.